morning, and welcome to this Oncology Data Advisor interview, which today we're holding in honor of National Minority Health Month in April. And I'm joined by two of our editorial board members, Megan Claire Chase and Dr. Jasmin Hundal, who are here today to discuss this topic and shed some light for National Minority Health Month. So with that, I will turn it over to Megsy to take it away.
Thank you so much, Kira. Hello, everyone. So, yes, it is National Minority Health Month, and the theme for it is advancing commitments to eliminate health disparities. The theme is to encourage individuals, organizations, and communities to work together to improve health outcomes for minority populations, particularly in addressing disparities in healthcare access, treatment, and overall health conditions. Now, before we dive into that kind of conversation, just a real quick introduction of myself. Yes, I am Megan Claire Chase, aka Warrior Megsy in Cancerland, and I am a 9-year invasive lobular breast cancer survivor, patient advocate, and writer. And I live in Atlanta, Georgia. And I'm going to toss it all over to Jasmine.
Hi everyone, my name is Jasmin Hundal. I'm a second-year hematology oncology fellow at the Cleveland Clinic with a special interest in disparities in healthcare as well as breast cancer. Looking forward to this discussion today.
So I was thinking about this year's theme, right? And something that has always been, part of my journey, and many that look like me, people of color, is that patient-doctor relationship and that trust. Because when I think about, the disparities in healthcare access, well, I think a lot of that is also about the lack of trust coming to even see a doctor and being believed. So I was wondering, before I go into some of my own experiences, what have you learned or experienced, maybe some examples of like how pivotal it is to have that trust and have that patient-doctor relationship?
Yeah, I think definitely it's very, very pivotal. I have a background in master's in public health that I did during my residency. So that's where I kind of like I was always interested in learning more about the disparities in healthcare because um during residency I saw the gap in healthcare, and especially our clinic was serving like underserved populations. So that was definitely a very eye-opening and very rewarding experience that I had because I was able to, be their primary care physician. It was so nice to always see how appreciative they were. But also on the other side, I did have an eye-opening patient encounter experience once where I was astonished by what I heard because where the patient of color was, and then she was diagnosed with a malignancy, and then she was just delay in care and seeking care. And the reason why there was delay in seeking care is because she had one experience with a medical physician, which kind of just left her distraught, and she felt like she was a fly on the wall. Um, she just found herself very judged. And like after that, although she knew she had the malignancy and she requires treatment and follow-up, she just parted her way from healthcare for a little bit because of that experience that was of significance. So since then, like since now I'm in oncology, and that was like, towards my initial, actually one of the first oncology outpatient visits that I, was in participated in, and that kind of left me with a very significant thought that I would never ever would try to, do my best to hear my patients, listen to them, and trying to see where they're coming from, because I think sometimes we do have these biases, like even if they're in our subconscious or somewhere, or what we learned or from where we are, to always hear out the patient. And I feel like also, as you said, um there's mistrust in healthcare, and I think there's a root behind it, and it stems from our local communities, and especially I think it varies from city to city, as my prior residency was in Connecticut in the Hartford area. So I got to learn like how Hartford community feels about it, because we did go out to the community as part of my MPH and everything. So I think all these experiences are very like eye-opening, and I think as being in healthcare, I feel like having that experience, I feel like will be incredible if every residency, fellowship, training experience has that, where you go actually into the community and listen to them, because I feel like every community, especially after that Hartford experience where we went to the community, I realized and I learned that where I was taught, or like they told me that, every community has a different reason why there is a mistrust. And Maggie, would love to hear like your thoughts on this from a patient perspective, like how you feel, and if you think that my current thought process is right, or no, like I should change how I'm thinking about it.
Well, I mean, I love the fact of like going to the communities because
Mhm.
I feel like that is also where there's a large gap in that thought of, well, if we just show that we're trustworthy, but then you don't like come and meet in the middle or find out who are like the community leaders within that city or that particular area, wherever it is where you are practicing. I think that's a really big deal because it always feels like it's on the patient or the communities to like come to the doctor, and that's not the way it should be. It should be going into those communities. Maybe it's a church, depending on which communities. And because if people see that you are making an effort to talk to someone that we really respect in the communities, and they're saying, hey, they're making this effort. I feel good about it. I want to make sure that you know about this because your health matters. But also, as a patient, something I learned, and it has followed me and it continues to follow me, is not being believed and being talked down to by too many doctors. And I thought to myself, wait a minute, I'm educated. I actually have like some health literacy. And I realized they a lot treat us all in the same bucket. It doesn't matter where we come from, what part of town we're in, how our education, anything, we're all treated the same. And that has really disturbed me. And I don't even I find the word minority problematic. Like I don't even like saying, oh, it's National Minority Health Month. I find that problematic. I don't like that label because it does not sound uh good. It's kind of like that undertone of, yeah, you don't really matter. It doesn't reflect what's actually going on in these communities. I'd rather be, you know, say that we're minoritized. Like we don't call ourselves a minority, we were minoritized. But when you go to a doctor and your symptoms are different. Like I consistently tell people when I am advocating and talking to like I talk to fellows, I've talked to some residents and just like the general community, I always say like our symptoms may present differently. And then the doctor will be like, oh, I don't think it's anything to worry about. You just need to, lose weight, eat better, blah, blah, blah. Or, oh, I don't think it's from that medication. And it really wasn't until my own experience of going through breast cancer and once I had like even with some of the chemo, I would have like reactions that would hit so sudden there was no way to even like adjust the dosage, like the damage was already done. And that's when it really started to hit me. Oh my God, people that look like me were not part of the clinical trials, or like we're going to sometimes experience rare or side effects that have never been reported with that medication, but we really need our doctors to believe us when we tell them this is what we're experiencing. Because honestly, the fact that I was being gaslit for over 2 years, I actually had to stop for a little bit because I was like, I know something is wrong and no one is like taking me seriously. And what if I had decided not to keep pushing after taking a little break? Like that is what is so scary.
Yeah, I that's definitely eye-opening. Your experience going through it. And I think knowing and reading and more like being on the academic side, like learning like how we have different pharmacodynamics and how they're different, like how we metabolize certain medications, and we do know there are differences, right? Like we have identified, and of course not many at all. We're just scratching the surface right now because now we're becoming increasingly aware about it. And as you said, like clinical trial representation, right? That matters a lot because like the adverse effects, there is always an adverse effect portfolio reported, right? But like if you look at the breakdown of the race and ethnicities, the majority are going to be Caucasian and white, and other patients of different ethnicity and race groups are definitely the on a less numbered compared to the white Caucasian. I think that's where a clinical trial enrollment is very, very important. I think we need to like educate our population more. I come from an Indian my background is Indian, so you know, educating our population, our society, whether going to churches or social media platform, how much important it is to a voice for yourself, like explain what's going on, and also be part of clinical trial or like the research endeavors, because I think that is very, very important for us to start seeing and studying the different biology of different race and ethnic groups.
I mean, I also think about how do we like I think there are different ways to talk about it. Like I'm always telling people that the way we talk about, that patient-doctor relationship, or the way we talk about clinical trials, or the way we talk about cutting edge research, it has to be like tailored to that community. And I'm even thinking within the community, then the age ranges too, right? And so I like to call them conversation starters, because a lot of times we don't want people in our business. Like we don't want to tell, that Uncle Johnny's leg over there, it was really bone cancer, but no one in the family knew that. And so I think it's not just having conversations within the family to know your family history, but your family medical history and anything. Like, even if you don't know if it's cancer or
Yeah.
not, even like saying, yeah, your great great grandmother actually had this. We're not really sure what that was, but the more info that you have, the more you'll be able to share that with your, provider. And that also starts to build some trust,
Mhm.
you know? And I also, it's, I think it's a matter of doctors and fellows and residents like really need to realize that a lot of the issues of that trust, that stain on our US history here, it
Mhm.
wasn't that long ago. Like so many things, like it wasn't that long ago. Like Ruby Bridges is still alive,
Mhm.
like, and so when you think about it in those terms, we're very much like this is still happening, where sometimes I
Mhm.
think our providers and even like the staff at the cancer centers
Yeah.
or community hospitals aren't recognizing that we're still within this. Like we've never been out of it. And
Mhm.
if we aren't given and shown that respect as soon as we walk through the door, like there have been so many times. I'm like, how many times do I have to tell you that my first name is a double first name? Like, how many times do I have to tell you, like, please don't speak to me like that? And you're
Mhm.
already coming in like a fragile state. I should not
Yeah.
have to dress up to go to the doctor. I can't show up with a messy bun and, lounge clothes in order to be taken seriously, because I see the judgment as soon as I walk in the door.
Mhm.
So what do we
Yeah.
do about staff also? Because it shouldn't just all fall on the doctors.
Yeah, no, I think definitely needs like from an institution perspective, I think where I think the bigger, because it has to be not a bottom up approach, it has to be top down approach, and that's where like it starts with the healthcare system, like we're within the hospital system, right? Like one hospital, one clinic at a time, right? Because like we all go through training, we all go through um what our goals and what our objectives are and things as such. So I think like which is part of the orientation on onboarding, right? And I think it's very important to have a different session, and as well, especially like for cultural humility and being aware of cultural awareness, I guess I get more. And then I feel like just came to my mind actually, like it would be great to have actually someone from the community come and speak during that, awareness, or if or like like maybe pre-recorded videos, like nowadays, like we can have those things, and I feel like that will probably have a bigger impact where a patient can share their perspective on how they feel when they enter, because otherwise, like it's hard to like read like papers or like read like things until you hear from someone their lived experience. I think that is much more impactful than like reading something, like having hearing it out. um I think just brings an additional value.
mean, I couldn't agree more. It's like there's a person at the end of that data point, you know?
Mm-hmm.
And actually, that is something I would love to do is go around to actually all the medical schools and then the hospitals and talking to medical school students and talking to residents and fellows and, doctors and the leadership there. Because like you said, like when you actually see a person and they're telling you, this is what has happened to me. And
Mm-hmm.
I am not making this up. Like, this is a real issue. And it is also like killing our community because
Mm-hmm.
we will wait until we are almost like, dying essentially before we will go to the doctor because it only takes that one bad experience
Mm-hmm.
to completely like turn us off and be like, well, no one's ever going to believe me. And I've had to like really have lots of talks with myself to be like, no, you matter. You know something is wrong. You keep pushing. But I'm also thinking too, as we think about Minority Health Month and just say minoritized health month, is what if English isn't your first language? And something I have learned is that in some languages, certain medical terminology does not translate. And
Mm-hmm.
so it always concerns me when I hear that someone's bringing in a family member, and I'm like, that's a kid who is trying to translate really complex medical information. And I know not every hospital or cancer center has translators, and I think about especially those in the rural areas, and I'm like, how much information gets
Mm-hmm.
missed, lost in translation?
Yeah, I definitely agree. Like different languages have different, um, just thinking about my mother tongue, right? Like in Punjabi, like if somebody says their heart feels like weird, like it has so many different, like if you literally translate it into like heart palpitations, like there's no word, like it'll be like it can have 100 different types of interpretations. So you're totally right in that. And I think that is where I feel like AI is very promising, right? And I feel like that is where AI is needed and can be utilized, like very and have a significant impact, because I feel like the AI, like the language models are can be trained at like the language like a translation in real time, and I feel like it can provide probably more to it, and then it'll be much easier and then like less access, like instead of like calling the language line and then like all these hazards. And I feel like that will just break down barriers. So I'm really really hopeful that with the with AI, we can hopefully close, like, definitely decrease this gap, which is super preventable by having a translator. And, one more thing that I just wanted to share is I've seen the difference in-person translators versus using the phone translator.
Mm-hmm.
We had sometimes in Cleveland Clinic, we have the opportunity of an in-person translator, and I've seen, and this is like comparing a Spanish phone conversation versus a Spanish in-person translator. It's so much different. And the patient, I feel like, is also much more, has a higher tendency to share their things because they have that personal touch and they feel heard because there is someone from their background or can they hear them. And I think it just is another a great example, like where in-person translator is definitely better. But again, it's like hard to have someone always there.
Right. And another point about that too is when you're on the phone with someone and you're, and t- translating
Mhm.
for them, it's you don't know, maybe they could be hard of hearing, so you don't know if they are really like understanding what you
Right.
were saying. So and I still, as much as we want to have in person, I'm also very aware that sometimes people, they may not have the transportation, or they have to
Mhm.
take a bus line and the bus line doesn't get close to where they need to be treated. So it's like even something virtual,
Mhm.
I still feel telehealth is so important. Yes, there are certain times where you definitely need to be in person, but for certain things like that, if you can't get there in person, I think it's always important to have like option A, B, C, and D, right? And also it's like we really want the doctors to also, when we are there in person,
Mhm.
to read those nonverbal cues,
Mhm.
because whether people know it or not, the face is expressive. And I'm wondering, like, is that something y'all are taught, like when, because I remember we talked last year, and I loved what you said when I was getting upset about why are the doctors always asking me why I'm here? Like, I'm like, made the appointment, like you should know why I'm here.
Yeah.
And so I was wondering if you could like say like why doctors say that even after you told the nurse that, because I that's like another piece of information that
Yeah.
we need to get to our communities, because then we get like offended. I mean, like, do you think I'm stupid and you don't know that I don't know why I'm here?
Yeah, that is a good question, and it's usually that is actually a question that I usually actually my most common thing is like, oh, what brings you in here today? Like, like of course like what brings you in here today. I think it's just like we've been trained and we'd like to ask a question to hear from the patient's perspective, like why they're here. And you'll be surprised sometimes they are scheduled for let me say like for a hypertension checkup, like just make like, and then but they actually have something else that they want to share with you. So like we don't want to like preclude like, oh, like that is our assumption or that was the reason for the appointment or the consult was like hypertension management, but perhaps the patient wants to really share something else with you. So I think like just coming up, we always like to go with an open mind into the room. And that's why we always ask like, oh, like, what brings you in here today? Just to see if there's anything else that was missed. And perhaps like, like things could come up in between like making the appointment until like the patient sees the doctor, or even like the MA leaves, right? The medical assistant leaves, and then they're like, oh shoot, like I was gonna talk about my diabetes, like, but if I just come like, oh yeah, we're just gonna talk about blood pressure today, then the diabetes is going to be missed because I never really asked the patient, like, hey, what do you really want to talk about today?
And I'm telling you, I'm going to figure this out, because this is something I really want to like impress upon providers is
Mhm.
I say it's not enough to say that to a patient, especially of color. I always like to preface like there's Black people and then people of color, because just historically how Black bodies have been treated. But like, I think it should be a step further saying, hey, I'm going to ask you what brings you in here today. I know you already told the nurse, but I just want to hear it from you.
Mhm.
And like that right there, be like, then I'd be like, I think people be like, oh, all right. So that actually makes sense. And,
Yeah.
so it's like, I just feel like communication. And as we
Mhm.
work towards that patient doctor relationship, I mean, and I'm highly aware, like I'm a big communicator. And not everyone is a big
Mhm.
communicator, but I think just that like extra line of saying, because
Yeah.
I just want to hear it from you would be a change maker.
Yeah, no, I actually agree with that. What I've started to do from experience is, how some, of course, we have like your prior charts and we read through the notes usually. And if you're in the hospital and you're a consultant, like you go see the patient, and sometimes we ask like again the same question as you said, like, what brought you to the hospital? What happened? And then the patient gets frustrated, like you should know, like, you know what I mean? Like you like because their assumption is like that we know, right? And I've started to say that that sentence after like, can you just briefly describe me what happened and what not. I know I've read the chart, but I'd like to hear from your in your own words, because I don't want to assume anything. So I started like playing around with how I word it, and I've seen different responses, like, good positive responses from that, because they don't get like it's frustrating for the patient to just, especially when they're in the hospital admitted, like there are like sometimes 5 consultants on the team, and like every consultant's gonna ask like, what brought you into the hospital? But that one sentence, as you said, like, I just want to hear from your own words, so that I know that what it's important to you makes a huge difference. So I should start adding that maybe sentence in my outpatient role too, because I added usually either when I see the patient for the first time, or during the hospital, like, because that's the first time we're seeing the patients. But I guess for follow-ups, I think that's a good reminder. I should like do it regardless, not like when I'm just seeing the patient for the first time.
I mean, yes.
Yeah.
And something else, when I think about like to help in those disparities is I remember I was talking to some fellows where their specialty was palliative care, because I
Mm-hmm.
happened to be in palliative care at that time. Yes, I do not look like I would need palliative care, and I think a
Mm-hmm.
lot of people still don't understand the difference. So I do think that term is even problematic. It should be called supportive care. But it's because I'm in chronic pain. Like even as we're talking, I'm in pain. And when I was telling my whole cancer story, which is very intricate,
Mm-hmm.
and I was telling them about when I had to have surgery and spend the night, and how freaked out I was because I hadn't spent the night in a hospital since my birth. You know what I mean? And it really like hit them. The fellows were like, we had not thought of that this could be like the patient's first time since they were like a child spending the night in the hospital, and what that could feel like, and the fear. And I just, it was so, it made me feel hopeful for the
Mm-hmm.
future, in that I was able to share with them something that they just assumed that a patient would be like, oh, they know they're going to be in the hospital overnight. But recognizing, hey, this could, let me walk you through what might happen. You might hear a nurse come in, or you're going to hear beeping, like to really help prep the patient. And so it's like, I feel the way that we're going to keep working towards uh, bridging the gaps is communication, and just
Mm-hmm.
recognizing that even with so many different cultures and ethnicities, etc., there are a lot of similarities, and we just want to be talked to in a way that is respectful, where we feel
Mm-hmm.
heard, seen, and believed. And that is, you got to be able to communicate with the patients. And you had mentioned AI, and I just want to like kind of tie that loop again with you. I was at ASCO on a panel, Quality Care Symposium, last year.
Mm-hmm.
And that's what we were talking about. And I was the only patient on the panel. And another way I feel AI is really going to help is the doctor's notes, because so many times I'm talking to, whether it's, my breast cancer surgeon or another specialist, and they're typing and not looking at me.
Mm-hmm.
And I really feel AI will be a really great tool to be able to capture, or in dictation. So that way the eye focus, like you're looking at me, I'm looking at you, and like really engage, because
Yeah.
when you turn away or you're looking down, it really, it's like, it's a very personal type of thing when you're in that appointment, when you're in that exam room, and it's just you and that doctor. And it's like, that's what we need to foster more. So I feel like AI can play that like supporting character, and helping doctors with some of the more like administration stuff. So then they can really focus on the patient and not be thinking about the next patient either.
Yeah, no, I agree. And you know what? I'm really excited. We're actually gonna have like the AI, ambient AI, at the Cleveland Clinic. We're introducing it. So I'm like really looking forward to using it. Like I got just that email actually yesterday, like how to download it and how to use it. So I'm like really excited. because I was like reading the doctors, some of the testimonials who piloted it. And as you said, like they were very like happy, and like one of the resonating themes of those statements were how they felt present during the appointment because they were actually able to focus on the patient rather than on note taking. As you know, like note taking is really important for us as well. Like we need to be um yeah, we need to like be, you know, efficient, like not efficient, sorry, that's the wrong word. We need to be detailed and being ensuring that we have all the details collected in order to make a good assessment and plan for the patient that we're seeing. But I think with the use of AI, like, you know, if they're listening and we can just totally focus our attention and not worry about that we're gonna forget like the detail that, you know, you might told me. So like yeah, so it's really, really exciting.
Ooh, we'll definitely have to have another conversation
I
about it.
know. Yeah,
Uh,
definitely.
yeah, I mean, talk about the future is here.
Yeah.
But I just want to thank you so much for this engaging conversation. And I really hope that, those in the medical community and even the research community, listen or watch this episode because I think there are a lot of great insights into how to bridge that gap within the different communities of color.
Yeah,
So,
no, this was definitely a great conversation, and thank you so much for sharing like your perspective. And I feel like I definitely took to take a point away, so I'll definitely report back how I adapt that into my patient encounters and how it goes.
oh, thank you so much. And thank you, Oncology Data Advisors.
Awesome. Thank you both so much. These are always the best conversations, and it's so educational and informative for our audience, and always learn so much from both of you. So thank you again for coming on today to share your insights and your perspectives on this.